although it has been over a decade since AIDS made its medical debut in the United States, this frightening disease is still with us today in even greater numbers. Why haven't we been able to find a cure, and what challenges does the future of this disease hold? Dr. David Fleming, state epidemiologist, is with us today to discuss the issues confronting Oregon as we enter the second decade of the AIDS epidemic. Specifically, he believes that there are two factors influencing the course of AIDS: evolution by the disease and inattention by society. Prior to his appointment as state epidemiologist in July of 1992, Dr. Fleming was deputy state epidemiologist and head of Oregon's communicable disease programs. He also spent 3 years with the Centers for Disease Control. A graduate of Upstate Medical Center in Syracuse, New York, he interned and did his residency in internal medicine at the Oregon Health Sciences University here in Portland. He has been actively involved on a national level with many issues of public health policy, particularly as it relates to AIDS. Please join me in welcoming Dr. David Fleming to the City Club.
Thank you. Good afternoon. It's a pleasure to have this opportunity to speak with you folks today. I specifically welcome the chance to talk with you about AIDS as we enter the second decade of this global epidemic, and hopefully to provoke some discussion as well. It's interesting, though, that as this first decade of the AIDS epidemic has worn on, it's become harder and harder to talk about AIDS. 15 years ago, what we now know as the reality of the AIDS epidemic would have strained the credibility of a pulp science fiction magazine. Not many people would have bought off on a plot line in which a previously unknown virus suddenly emerges in Central Africa. This virus has the ability to infect the key cell that controls our immune system and is able to mutate so rapidly that it's able to avoid our body's defenses and thwart the development of a vaccine. The virus possesses a unique enzyme that enables it to insert its own genetic material into ours permanently, thus essentially eliminating the prospects of a cure. People unknowingly infected with this virus spread it to others by sex, by blood, and from a mother to her unborn child for years or decades before developing symptoms that might alert them that they're infected. The ensuing epidemic spreads around the world virtually unchecked in less than a decade. And finally, this virus causes one of the most lethal infectious diseases known. The facts of AIDS do make for a riveting story. The problem is that we've heard them now for 10 years. Human nature, media hype, and information overload being what they are, we now accept these horrifying aspects of the AIDS epidemic without giving them a second thought. The danger we face is that while the alarm that sounded during the first few years of this epidemic is still ringing, we've lost the ability to hear it. The AIDS epidemic isn't waning, but people's interest in it is. And that was my problem in preparing for this afternoon's talk: what to say in yet another AIDS talk. Even epidemiologists aren't immune to AIDS anesthesia. By the way, for those of you who may not ever have met one before, epidemiologists are people who worry about the effects of diseases on populations rather than on individuals, and are occasionally described by those in clinical medicine as doctors gone bad. Several years after the AIDS epidemic had first been recognized, I was in a conversation with a younger epidemiologist and an older one. The younger epidemiologist was concerned about his career and was trying to figure out where the future of epidemiology was going to be. And he was complaining about having missed the AIDS epidemic. Quite accurately, he was saying that the virus that causes the disease had been discovered, and its structure and its genetic sequence were being analyzed in detail. The ways the disease could and couldn't be transmitted had been discovered and reaffirmed in multiple studies. Risk factors for acquisition had been described down to the smallest detail. Studies to monitor the infection rates around the world were in place, and information was coming in. What was left to do? The older epidemiologist's reply was brief and rather to the point. He said, maybe now we should be thinking about how we're going to stop it. Historically, some have claimed that the reason that epidemiologists have been very good at predicting what you're going to die from is that we're not so good at changing the things that are going to cause your death. In the absence of an effective vaccine or a miracle cure, we as a society find it tough to change those things that we choose to do in our daily lives, and consequently, tough to change the circumstances of our deaths. As we enter the second decade of the AIDS epidemic, although we know so much about this disease now that we're bored of it, this knowledge hasn't yet and isn't necessarily going to translate into an ability to stop it. I'd like to talk a little bit about where we are right now with the AIDS epidemic. AIDS is caused by human immunodeficiency virus, or HIV. Back in 1980, an estimated 100,000 people worldwide were HIV infected. During the 1980s, the number of infected people in the world increased 100-fold, such that by today, 13 million people are infected, including 5 million women, 7 million adult men, and 1 million children. An additional several million children have already been orphaned by AIDS. In the next 3 years, more people will develop AIDS than have during the entire history of the epidemic to date. Today, most people who are HIV infected live in Africa. There are probably about 1 million each in North and South America, perhaps 500,000 in Europe. Yet it's in Southeast Asia, in Thailand, in Burma, in India, where right now this epidemic is most violent. The number of people who have developed AIDS in Thailand will increase from a handful over the last 5 years to an estimated 80,000 during the next 5 years. A massive heterosexual epidemic is underway right now in India, and already at least 1 million people in that country are infected. In 1981, 189 cases of AIDS had been reported in the United States. By the end of 1992, 253,000 cases of AIDS have been reported. About 1 million people in this country are already infected with HIV, and it's been estimated that during the next 3 years, an additional 120 to 240,000 people will become infected. Oregon's representative of the AIDS epidemic in this country outside a few high-incidence states like New York and California. A decade ago, 5 cases of AIDS had been reported in Oregon. Today, we're just shy of 2,000. When you rank order the states by cumulative AIDS incidence, Oregon's 21 out of 50. And while we don't know for sure, we estimate that there are 8,000 to 10,000 infected people in our state right now. We do know how many people are newly diagnosed with HIV infection each year, and the news here isn't great. Currently, each year, there are more than twice as many new HIV diagnoses in Oregon as there are reported AIDS cases. These new diagnoses represent the AIDS cases of the future. And we're seeing the biggest increases in women and in adolescents in our state. The figures for adolescents make me particularly nervous because they're borne out by information we have about other sexually transmitted diseases. Who gets sexually transmitted diseases is a fairly good measure of who's at risk for AIDS. Today, the rates of sexually transmitted diseases in Oregon are higher in people age 15 to 19 than any other age group. While this information is interesting, I realize that the bottom line question boils down to, so what's going to happen? In medical school, there's a fairly core concept about health outcomes that's usually truly learned during the 3rd year when you rotate through the emergency room. Simply put, it goes something like, one way or another, all bleeding stops. The trick is to make it happen while the patient's heart is still beating. The same concept applies to epidemics. One way or another, the AIDS epidemic is going to end. The process has started. We put our quarter in and the ride has begun, and no amount of either hand-wringing or inattention on our part is going to change that. What's at issue now is how many people are going to die before this is over. We can look backwards in history to get an inkling of what usually happens in epidemics. While it's fairly self-evident that there's never been an epidemic that's wiped out the human race, individuals or groups of people haven't been as fortunate. When the bubonic plague arrived in Europe by the Silk Road from the Middle Ages, from Asia in the Middle Ages, 1/4 of Western Europe's population died in a 4-year period. In this century, the influenza epidemic of 1918 ranks as one of the worst disasters in human history. In less than a year, this quiet epidemic, fueled by the conditions at the end of World War I, killed 20 million people, including 500,000 in this country alone. Epidemics tend to follow a typical pattern of a quick rise to a sharp peak, followed by a gradual descent. Quick is a relative term, however. For syphilis, the great pox of the 1600s that was widely disseminated as a result of the newfound mobility of military troops, this peak mortality period lasted 50 years. For tuberculosis, which became epidemic in Europe as the result of the crowding of the Industrial Revolution during the 1700s, the complete epidemic cycle took 300 years. Because AIDS is new, we're on the upswing of the epidemic curve. The epidemic is still dynamic, it's still volatile. Its major impact is yet to come, and we have the opportunity to influence it. But if we don't act, regardless of which persons were first affected with HIV in the community, HIV will spread through all available routes until the population of susceptible people has been exhausted. At least this is the pattern common to the epidemics of the past. In the past, because we as a society had been unable to mount an effective response, the course of epidemics has been determined at the level of the individual. At this level, outcome is determined by the rules of biology, not sociology. Susceptible organisms continue to die until only resistant organisms are left, and there's no value given to preserving life. I don't think we want to play by these rules, but in our lifetime, we've grown complacent. We've had too many recent victories where a vaccine or a cure has provided an easy, instant solution. Now, hopefully, technology will come to our rescue for AIDS too, but it hasn't yet, and it may be a way off. In the interim, we either think about ways that we can stack the deck, or we default and play according to the rules of Evolution 101. What are our options? What can we do that will put us more in control of this process? Well, the basic of problem solving is to capitalize on your strengths. Are there differences between humans and human immunodeficiency virus that we can exploit to our advantage? Today, I'd like to speculate about a couple of such potential differences. The first difference, in contrast to HIV, humans have money. Money translates into the ability to bring to bear collective resources beyond those possessed by an individual. How successful have we been on capitalizing on this advantage? Well, I've heard many people say that, if anything, AIDS is overfunded. They point to a federal budget for this disease of over $1 billion, and they say, well, it's less than cancer, it's more than heart disease, and it's too much, period. Are they right? Well, one could argue that there are compelling counter-arguments for why AIDS funding should compare favorably with heart disease and cancer. Unlike these other two diseases, AIDS is communicable. It's spread from person to person. AIDS primarily strikes the young. Right now, today, AIDS is a leading cause of death in Multnomah County in men aged 25 to 44. And AIDS is epidemic. The number of AIDS cases today is only a fraction of what it will be 5 years from now. But I hate to use these arguments because they buy into the underlying premise that it's okay to gauge the appropriateness of AIDS funding by comparing it to that which is allocated for other diseases. Instead, maybe it's more appropriate to see how AIDS funding stacks up against items unrelated to health. For example, the amount allocated to AIDS last year was about the same as a stealth bomber and maybe half the wing of a second. It was about 6 times less than we paid farmers not to grow crops, and 30 times less than the military's annual research and development budget. And when compared against what this nation spends on health care, or more accurately, disease care once people get sick, AIDS prevention funding was on a level that we might not even worry about getting a receipt for it. Perhaps most fundamentally, though, we need to remember that the money used for AIDS prevention represents money saved, not money lost. Last year, the estimated cost for providing health care to HIV-infected people in this country was $20 billion. Each new HIV infection is going to require up to $100,000 in direct health care costs. Effective prevention programs avoid these costs. Our decision really isn't how much do we want to spend on AIDS prevention today, but how much do we want to save on AIDS care in the future. A disease that's been in the news quite a bit recently, tuberculosis, provides a case in point. After the advent of antimicrobial treatment, funding for TB public health programs in this country languished. In the 1980s, the Secretary for Health brought this to the attention of Congress and advocated for the estimated $36 million per year it would take to correct the problem. Nothing happened. Today, with the appearance of drug-resistant tuberculosis, with the spread of this disease into the HIV-infected population, and with the further erosion of our public health infrastructure, the federal government now estimates that we're going to have to spend about $500 million a year to control tuberculosis. Again, our decision really isn't how much do we want to spend on AIDS prevention today, but how much do we want to save on AIDS care in the future. Right now, today, only about $150 million federal dollars actually go to states and cities for conducting AIDS prevention activities. In the last 2 years, contrary to conventional wisdom, this amount hasn't increased. It's decreased by over $30 million. In Oregon, we're spending less on AIDS prevention this year than last year. And we have consistently spent far less on AIDS prevention, even on a per capita basis, than either Washington or California. Now, the governor's current budget does propose that money be made available for HIV prevention programs in Oregon that work. And while the legislature has identified prevention as a key criterion when considering funding issues in general, obviously, they have not yet decided on the funding for HIV programs in Oregon. So as far as money is concerned, the picture is mixed. It remains unclear, at least to me, whether this difference between HIV and us is one that we're going to choose to exploit. What else can we call on to make the rules of this epidemic more in our favor? Well, a second difference between HIV and us is brains. HIV isn't smart. We are, at least in theory. The money we were speaking of will be of little use unless we combine it with innovation, creativity, and knowledge. So have we been doing this? Again, the picture is mixed. We haven't been using our brains when we've let politics, rather than public health, determine AIDS policies. When politics is mixed with AIDS, particularly at the federal level, results have included bad decisions, delayed decisions, or no decisions at all. Just about a year ago, at a press conference, the then Secretary of Health summarized the administration's philosophy regarding the direction of AIDS prevention activities in this country. He said, quote, "There are certain areas which, when the goals of science collide with moral and ethical judgment, science has to take a time out," end quote. What did he mean? Well, the House of Representatives Committee on Government Operations recently released a report entitled, interestingly enough, "The Politics of AIDS Prevention, Science Takes a Time Out." The primary conclusion of this report is that the Federal Centers for Disease Control's attempts to provide leadership and to apply a rational scientific approach to suppressing the AIDS epidemic has been repeatedly stymied by political pressure. The report's probably right. Let me give you a classic recent example. Most people get AIDS because they have sex with multiple partners. If you decided you're going to have multiple sex partners, the best way to prevent getting AIDS is to use a condom. Now, Congress has authorized the Centers for Disease Control to spend several $1 million to develop a public information media campaign to slow the spread of HIV in this country. The most recent batch of slick and expensive America Responds to AIDS spots was released last year. Unfortunately, there's one problem. In the ads, the existence of condoms remains a well-kept secret. In fact, no ads showing the risk of having unprotected sex or sharing dirty needles are included. In fact, the word sex isn't even mentioned. While ads explaining the role of condoms and containing HIV prevention were developed, they were disapproved by administration officials and were withdrawn before being shown. This example isn't an isolated one. Although I'll spare you the details, another recent example is the peculiar situation in which states now find themselves with respect to HIV-infected healthcare workers. Congress has mandated, under the threat of loss of all of our public health funding, that we certify compliance with a set of CDC guidelines that CDC has publicly stated cannot be implemented and has tried to retract. Now, I don't want to imply that politicians have a monopoly on not using their brains to confront AIDS. Many of us have been guilty of that at one time or another, usually when we've allowed ourselves to be sucked into assuming that an easy solution is the answer to a difficult problem. Again, there are many examples. Let me give you just one. A frequently heard proposal for solving the AIDS crisis goes something like, just simply treat this disease like we treat other sexually transmitted diseases and have mandatory contact tracing of sex partners of infected persons. If it's good enough for syphilis, it's good enough for HIV. Thank you very much. Next problem, please. This approach seems rational until you take the time and effort to consider the counter-arguments. Perhaps the most compelling is that despite 40 years of partner notification programs, a syphilis epidemic is raging in this country today. For a variety of reasons, aggressive partner notification can't control epidemic syphilis. And we must accept that it's not going to control epidemic HIV either. As a consequence, while we do partner notification for HIV in Oregon, we've been forced to recognize that this resource-intensive activity is only a small part of the solution. Okay, enough about not using brains. It's also important to point out that we've had successes against HIV when we do. In general, we've done well when we've been innovative. Witness the recent example of the Harvard medical student who developed a new concept in drug therapy for HIV because they thought about the problem differently. Or the researchers who are now expanding with HIV vaccines, not for the uninfected, but for the infected, to slow their progression to AIDS. In general, we've done well when we've let outcomes rather than opinions drive policy. Whether or not HIV testing should be offered anonymously was a hot issue in the mid-1980s when the test was first developed. Rather than making an arbitrary policy decision, the Health Division was allowed to offer anonymous testing on a trial basis. The day the trial started, the number of infected people coming in for testing doubled, and that trend and this policy has continued to this day. In general, we've done well when we've made sure that we understand the problem, including its social context, before developing the solution. An example, we're very interested in providing AIDS prevention education to street prostitutes in Portland. Our initial thought was that a pretty good way of doing this would be through some sort of self-help group that capitalizes on the informal social network that prostitutes have. Fortunately, we talked to some of these women before implementing the program. I'll tell you, movies like Pretty Woman and Risky Business got it all wrong. On the streets, prostitutes move often, face savage competition, are frequent targets for theft and violence, and often have histories of abuse, both past and present. They don't have friends. There is no informal social network. What they need is a safe shelter to go to where their health and social needs can be met, and this is what we're attempting to do now. And in general, we've done well when we've gone to the community to do the education and to get the work done. Somebody like me probably does okay in a setting like the one I'm in today, but face it, I have limited street value. When you're talking about sex and drugs, people listen to their peers. Our most effective outreach programs to gay men were conceived by and are run by gay men. The person an injection drug user is going to listen to about how to clean their works is someone who's been there. And we all know that adolescents, perhaps with good reason, don't pay attention to much of anything that adults say. Okay, I've talked about money and I've talked about brains. Speakers are always told to make 3 points and to make their most important point last. So, the third and last exploitable difference between humans and HIV is that humans have compassion. How's this relevant? Well, basically there are 2 ways to approach this epidemic. One was stated fairly succinctly about a year ago by a gentleman named William Grigg, who was an assistant to the Secretary of Health under the Bush administration. When asked why federal HIV prevention messages did not seem to be targeted to those at highest risk, he replied, quote, "When you're fighting a fire, you control it from the outside and let the center burn," unquote. I don't think most people buy this. Out of compassion alone, I think most would opt to provide support and to promote the rights and dignity of those who are at risk or those who are infected. Many would argue that this alternate approach is not only compassionate, it's also a prerequisite for effective prevention. Jonathan Mann, who headed the World Health Organization's global fight on AIDS, has stated many times his conviction that the single most important step to controlling the AIDS epidemic is the creation of a supportive social environment. People aren't equal in their ability to protect themselves and others from HIV infection. Fewer resources, less information, and less social support translates into increased risk of exposure to HIV, a decreased ability to put into practice the implication of prevention messages, and spread of this epidemic. Whether it be the CEO of a major corporation, the sexually active adolescent naive about condom use, the deeply closeted gay man who's practicing anonymous risky sex, or the disaffiliated injection drug user who's just learned he's HIV infected and is about to go back on the street, the issue's the same. To win, we're going to need to provide all people, not just some people, with the knowledge and ability they need to fight off this disease. They say that in every crisis there's opportunity. Well, are we facing an opportunity as we enter the second decade of the AIDS crisis? In retrospect, for those great epidemics of plague and syphilis and tuberculosis of the past, society probably didn't have the ability to affect the outcome, even if it had wanted to try. For AIDS, we do. AIDS has been one of the primary forces leading our newfound commitment to address the health and public health problems this country faces. And while on some days we're still worrying more about inflation rates than immunization rates, and more about property tax assessments than prenatal assessments, we should be optimistic. The AIDS epidemic has served as a lens to focus our attention on some of the fundamental issues affecting our society. And if we choose now to transform our resources, our knowledge, and our compassion into action, we can correct these basic inequities that fuel the AIDS epidemic and a host of other health problems as well. This is an exciting time to work in public health. But public health can't do it alone. We need your help. We need your advocacy for prevention resources. People whose deaths are being prevented by AIDS prevention programs don't know who they are and can't stand up and be counted. The most effective prevention programs make nothing happen. And we need to be fighting for these programs as if our lives depended on them. We need your knowledge. If nothing else, talk to your kids about sex and about drugs. At best, share with the community your expertise. Be part of the public-private collaborative effort we need if we're going to get through this. And finally, we need your compassion, your leadership to help create the supportive social infrastructure we as a society need to allow our resources and our brains to work for us. In closing, the Harvard School of Public Health has estimated that by 1995, the number of HIV-infected persons in the world will rise to 20 million. And by the year 2000, they estimate as many as 110 million. I hope they're wrong. I know we have the ability to make it so. If we succeed, like most achievements in public health, it will be a silent, unnoticed one. I look forward to your help in achieving that quiet victory. Thank you.
Thank you, Dr. Fleming. We'll take our first question from Chuck Williams, followed by Chip Hudson, and then I would invite you to go to the microphone.
Dr. Fleming, I guess I'll ask you a question that's maybe a little bit unfair. You said you were an epidemiologist, which is who's a physician gone bad. Well, I'll ask a question that maybe should go to a sociologist. Maybe that's a social worker gone bad, I'm not sure. You alluded just a little bit to some of the behavioral aspects of this disease, and two audiences in specific, I'm hoping you can give us some more help and some specific information on women, younger women especially. And I understand women are more susceptible to the virus given the same exposure, men versus women, may be more easily infected. But especially I'm interested in what messages, if any, younger people, teenagers, adults under 25 will respond to. Are there any studies or any information about either who delivers the message or in what form, or what works to promote prevention in those two groups?
It's a very good question. And as I said, in Oregon right now, the information we have does suggest that the HIV epidemic is heading just into the two populations that you mentioned, that is, women and adolescents. There's been a lot of work done on this. Obviously, much of the prevention work that we do is not done in a controlled way. We don't offer a program only to some people and not to all people. But the messages that seem to work are, number one, the messages of support rather than the messages of fear. Fear doesn't work for anyone, and it particularly doesn't work for adolescents who think they're invulnerable. Messages have to be delivered by people who have credibility, but credibility for adolescents may be another adolescent and not an adult. And finally, while we need to target these populations, we need to remember that many of our behaviors around sex and drugs are determined by the society as a whole. And so to think that we can change the selective behaviors of some members of our society at the exclusion of others may be an incorrect assumption. Specifically with respect to women, there is a project going on right now in Portland where, in collaboration with Multnomah County, the Oregon Health Division is going out and talking to high-risk women in the inner city area to try to figure out exactly the answer to the question that was just posed. What kind of message is going to work the best? How do we get women to use condoms, as an example? One of the overwhelming responses that we get is that a message about condom use directed towards women probably isn't going to work. A message about condom use has to be directed to both partners, and probably more importantly to the man rather than the woman.
Dr. Fleming, I think perhaps you've answered the questions that I had considered before coming here, which involved the logic of our allocation of resources. But I wonder if you have any thoughts you could share with us as to how we might change our institutional structure so that some of these questions of allocation of resources and priorities can at least be addressed in a less political way initially, so that there is some medical or scientific as opposed to political statement that is made forcefully to the policymakers and the electorate. Have you given any thought to that, or have anything you could share with us?
I've given a lot of thought to it. I'm not sure there is an easy answer. I think that the answer, again, is a hard one, and that is that we collectively need to be working on our political leaders to make sure that when they're making their decisions, they're reflecting our viewpoints, but they're also reflecting what science and health and public health says we should be doing. I do think that there is progress here. It's really encouraging. 10 years ago, if you started to talk about prevention, you usually got a big yawn followed by a number of people leaving whatever room you were in. People have bought off on this prevention message now, and it's beginning to make sense to people that not only is it the rational thing to do, but it's the cost-effective thing to do. And so I think we're in a position now where we don't need to necessarily get those ideas into the heads of our leaders because they are already there, but rather to continue to let them know that we believe that they're the right ones.
I'm Frances Storrs, a member of the City Club. Dr. Fleming, would you tell us what, in your view, is the record of our local press, printed press and radio and television, in terms of receptivity to publishing and promoting some of the explicit sort of preventive messages that you described earlier? Does the Oregonian presently allow condoms to be described in their press as something that I guess they wouldn't do some time ago?
It's an interesting question. In general, number one, I'd like to compliment the media in Oregon. In contrast, when I talk to folks that work in other states, they're constantly complaining about how the press doesn't listen and how the stories that come out are sensationalized and inaccurate. And for whatever reason, in Oregon, that's not the case. And in general, I believe the coverage that we've achieved in the media on HIV issues has been good. And there are many people who are out there right now in media and in the newspapers who see this problem. They say, you know, I know that people are bored of AIDS, but I still want to get those messages out there. Can't you give me an angle? Can't you give me a twist on this so I can write another story about it? As far, though, as a specific question of the media playing explicit prevention messages, here our record is mixed. I think there has been an improvement. An example would be right now in Portland, there is a private group called PSI that is working on a condom promotion campaign. And they have produced a number of TV and radio spots. Not all the TV stations in Portland have agreed to run those spots, but some have. And again, we need to let the people who are making those decisions at the stations and in the newspapers know how we feel about this if we expect that to change.
I'm Ted Falk, a City Club member, and I was also a member of the City Club AIDS task force that 4 or 5 years ago published a report in the City Club Bulletin on this subject. Dr. Fleming, you mentioned HIV-infected healthcare workers as an issue that has been politicized by the federal government. I wonder what policy you would recommend from a public health standpoint.
It's a very difficult issue. The first thing that we need to be considering when looking at what should our policy around HIV and infected healthcare workers be is, what's the risk? What's the evidence? It's very clear that there has been one instance that everyone knows about in Florida where a dentist, in some way that we will never know, successfully transmitted his HIV infection to 5 of his patients. On the other hand, we need to look at the balancing, counter-arguments. As a result of that, and even before that, because people knew that there was this potential risk for transmission, there have been a number of studies that have been done looking for when you have an HIV-infected healthcare worker, particularly an HIV-infected surgeon, has that person, in fact, transmitted their infection to their patients? And with the exception of this one incident in Florida, in no other instance, despite having looked for it in thousands and thousands of patients, has there been a time when HIV infection has been transmitted from an infected healthcare worker to their patient. So the level of risk that we're dealing with here is very, very, very close to zero. That's one thing that we need to be considering whatever policy we come up with. The second thing, though, that we need to be considering is that there are 2 things that are balancing, that we need to balance in any policy that we come up with. One is assuring the public that their health is going to be protected. The second, though, is making sure that the system that we set up is one that doesn't inadvertently put the healthcare worker who may be at risk for HIV infection in a situation where he or she doesn't seek the tests because the consequences of finding out that information are so severe that they can't deal with it. I believe that the best policy is one in which healthcare workers who are HIV infected have the opportunity to consult with an expert panel that provides absolute confidentiality to the infected healthcare worker, and that panel can then advise the infected healthcare worker on whether or not anything that they do might pose a potential risk to patients, and if so, how to change that. In fact, that's been the policy that's been in place in Oregon long before the CDC even got worried about this, and it's worked quite well. We've had a number of HIV-infected healthcare workers who have come to us seeking consultation, in general, not in general, uniformly, the overwhelming concern on their part has been, do I pose any risk to my patients? And if so, what should I be doing to bring that risk down to zero?
Ray Polanyi, a member of the City Club. Dr. Fleming, what do you think now that the Oregon Health Plan seems to have gained some national credibility? What do you think are the implications for the Oregon Health Plan of the situation with AIDS and so on?
The Oregon Health Plan is going to do a wonderful thing for AIDS prevention in that it's going to make it so that people who are HIV infected, but perhaps not yet symptomatic or severely sick, can have the wherewithal so that they can access the medical system, so they can get the treatment that they need, and more importantly, so that they can get into a system where the behavioral counseling and the support that needs to happen can occur. And so in that sense, the Oregon Health Plan is a real positive approach. I need to say in the same breath, though, that it's not the only solution. Because it's a health plan, it deals with people, for the most part, who are already infected. And a key, if not the key way to prevent the AIDS epidemic from exploding is to reach those people who are not yet infected. So we can't sort of sit back and rest easily and say, okay, now we've taken care of the problem. We need to continue to advocate for those resources, and we need to continue to implement those programs that are primary prevention, that are preventing those people who are at risk from becoming infected.
Vivian Solomon, City Club member. If you had a hotline to Governor Roberts and another one to President Clinton, what specifically would you ask for or tell them?
Well, I don't, unfortunately, but it's nice. It's fun to think about. I think I'd give them different messages. The message that I'd like to get to Governor Roberts is keep the faith. Governor Roberts has been an advocate for AIDS prevention activities in Oregon. Governor Roberts has bought off on the benchmark process that the legislature established that said, what are our priorities? That benchmark process established HIV prevention as one of their most urgent priorities. And she has responded to that by submitting a budget that gives us at least some of the resources that we need to do a good job in Oregon. However, I'm sure that there are a lot of other issues that are on her mind right now, and so I would urge her to keep the faith on this issue. For President Clinton, I think the answer is a little different, and it, in a way, goes back to the discussion that we just had on the Oregon Health Plan. President Clinton, on a number of occasions, has spoken in very positive ways about AIDS. He, in his budget, has suggested that increased funding be made available for AIDS, and that's great. The funding, though, that he's suggested currently be increased is funding that goes to provide care for people who are already infected, specifically increasing the Ryan White allocations. While those needs are critical and need to happen, thus far President Clinton has not suggested that the money and the resources going into primary AIDS prevention be increased. There are a lot of us working to try to get that message to the federal level that says we need to be worrying about people who are infected, but we also can't forget prevention in the process. If I had the opportunity to call him, I'd tell him that directly.
Ted Kay, City Club member, you have told us a lot about the sociological aspects of prevention and dealing with this epidemic. Would you say a little bit more about the chances for a technological solution, the longer run solution that you were talking about?
We're talking about technology. I think we need to divide that into prospects for vaccine to prevent uninfected people from becoming infected, and then prospects for therapy. Let me start with therapy first. As I mentioned, HIV is insidious in that once you're infected with this virus, you will be infected for the rest of your life. Its genetic material is in your genetic material, and there's no technology right now, even on paper, that would allow us to extract that. Any treatment, therefore, that we're talking about for HIV is going to be suppressive, and by that I mean it's going to be treatment that once you are infected, you're probably going to need to take for the rest of your life. I'm fairly optimistic that we will make advances in the treatment that is available. There have been a number of drugs that have been developed that do, in fact, retard the growth of the virus. The problem is that the virus has the ability to mutate very rapidly, and so it's going to quickly develop resistance to those drugs, and so we need to continue to be developing those drugs. And I'm personally very excited about the idea of using the body's own immune system to fight off the infection. People, when they're infected with HIV initially, can go for a period of 5 or 10 years without developing any symptoms. Something is working right during that time. The body is managing to suppress the infection. And there are a number of people who are looking at and thinking about therapies that might mimic that so that we could prolong that latent period indefinitely. As far as vaccine is concerned, I kind of go on a cycle on that. There are very encouraging reports that come out, and then you don't hear anything for a while, and then there's another round of very encouraging reports. What I've incorporated is the need to look about vaccine development and its prospects in a slightly different way than I have in the past and the way that you may have. We typically think about vaccines as a way that once we give the person a vaccine, the problem is gone. They're 100% effective, and we can go on to worry about something else. Because of the way that HIV is, I would suspect that at least in the short term, vaccines that come out that are effective are not going to be 100% effective. In fact, they may be markedly less than 100% effective, 20, 30, 40%. We need to be careful not to look at that and go, oh, what a terrible vaccine, because a 20 or 30 or 40% effective vaccine is better than what we have now.
Peggy McCarthy, City Club member. It was shown years ago that about 70–80% of the residents in mental hospitals were tertiary syphilitics. Lewis Thomas has recently dealt with that in one of his writings, saying that this picture has changed. Physicians now almost never see a tertiary syphilitic, even though we have a syphilis epidemic going on. But this is attributed to the fact that physicians have indiscriminately used penicillin and its derivatives, and they're treating all these people with syphilis and controlling it. Are we doing anything at this point indiscriminately in the population that may be accounting for those people who are HIV positive who are living longer than others? Can you speculate as an epidemiologist what we might be doing, not really using our brains actively, but inactively, that may be stopping the spread or at least allowing people to live longer?
I've thought a lot about that. A lot of people have thought about that. And the sort of bottom line is we wish we knew. Studies that have looked at factors that might predict whether someone who is HIV infected goes on to develop AIDS in just a few years or remains asymptomatic for a longer period of time have fairly uniformly been unable to find factors, either personal or sociological factors, that allow you to predict that. So I don't have a good answer for you. It's a good question, though.
My name is Rich Truitt, City Club member. First, let me say, as a healthcare professional who works in disease prevention, I don't regard epidemiologists as doctors going bad. My question is, in the battle against AIDS, do you see the prospect of national healthcare reform helping or hindering that battle?
I think this goes back also to the Oregon Healthcare Plan issue. One of the problems with AIDS and one of the reasons why the epidemic is progressing as quickly as it is that many people, including those who perhaps may be at highest risk for HIV infection, don't have access to health services. And to the extent that that is a part of the problem, certainly national health care reform in which everyone has access to a health care provider will accept it. Again, though, we need not to forget that the best thing to do is to prevent people from getting infected in the first place, and therefore we need to be accessing people through ways other than clinics where they might come after they're sick.
I'll sneak in with one more question. You haven't directly spoken to the Gonzalez trial, and I'm wondering what you think about prosecuting people who are HIV positive who put other people at risk. Does prosecuting tend to result in better behavior or worse behavior by driving people underground?
Well, I think you've raised the the key points. This is a very, very complex issue, and obviously there are criminal concerns here and there's civil rights concerns here as well. Speaking from a public health standpoint, we have not ever, to my knowledge, successfully been able to legislate a epidemic to end, particularly an epidemic that you're talking about behaviors that are consenting behaviors among adults. So I'm not optimistic that legislation or criminal prosecution is going to make much of a dent in the problem. But more importantly is the issue of driving the epidemic underground. If the message, people who are at risk for HIV are already socially marginalized. They already have a lot of reason to fear discrimination. They already have a lot of reasons not to come in to seek HIV testing. My fear is that if criminal statutes go too far, that the messages are going to get out that the way to avoid this thing is just not to be tested in the first place. And so we need to be aware in whatever criminal statutes we come up with, we need to be careful that they don't have an adverse effect in the sense of making it so that those people who are at risk don't find out they're infected.
I'm Don Sterling, a member. One of the hot button issues around here, of course, is that of sex education in the schools and of health clinics in the schools. Would you tell us what you think of the value of those programs and specifically your reaction to the argument that if you tell them how to do it, they'll do more of it?
Gee, I've never heard that before. Let me talk first about health clinics. Health clinics are one of the key factors right now in Oregon that's allowing us to get STD prevention information, HIV education information, and other personal health information out to adolescents. We need to support healthcare clinics, and those of you who agree with me, I would encourage you to call your legislators and let them know that. As far as sex education is concerned, I'm a resident of Lake Oswego, and Lake Oswego has recently been going through this exact issue. In participating in that, I come away with two things. One, sex education that occurs in the schools needs to reflect the values of the community in which the school is located. But recognizing that those values are often diverse, we need to ensure that the sex education that occurs in schools meets the needs of all of the people in the schools. There is no evidence to suggest that telling adolescents about condoms will suddenly make them have sex. There's fairly good evidence to suggest that not telling adolescents about condoms will make them have sex, but they won't use a condom.
Polanyi again. Given the Oregon finance crisis at the general fund, what do you think is the likelihood of obtaining increased prevention funding? Is it realistic? Should it come from additional cigarette tax, lotteries, alcohol?
All of the above.
All of the above.
We need to realize that money that we allocate for prevention today is going to be money that we save in the future. I'm not sure whether that money is there, but to the extent that it is and to the extent that we can find creative ways to find it, we're saving ourselves the dollars in the future.
Dr. Fleming, we've enjoyed having you here today, but we'll hope not to have you back another decade, at least talking about this topic. Thank you very much for joining us, and we're adjourned.